There we go. So welcome everybody, or welcome back to our Black History Month conference. Hopefully this session will be useful for you. We're going to be going over the community health profiles and a bit about our wonderful engagement partners that we've been working with for the last couple of months. A bit about the conference itself. So this year, the conference title is Global Communities, Local Challenges and Partnership Solutions. And all of these webinars are going to be split into 3 different themes, either looking at shining a light on issues, celebrating and connecting with communities, or sharing emerging practice and learning. And that final one's going to be the theme of today's webinar. We're going to look at some of these amazing organisations that have been working to tackle some of the health inequalities in our Caribbean, Somali and Nigerian communities in Birmingham. And the main purpose of the conference just overall is we want to look at celebrating, we want to enable discussion, we want to help us move towards better solutions that help create sustainable change to the communities in Birmingham, and specifically for this month looking at our Black communities. And we really want to use this webinar as an opportunity to bring more visibility to some of these grassroots organisations that are doing brilliant community-led activity and research that doesn't always get seen and doesn't always get enough praise and visibility. So just a quick little rundown of what the agenda is going to be today. So we're going to spend 15 minutes listening to me first, just quickly giving us an overview of the community health profiles and the data that has helped shape the work that our engagement partners have been doing. And then they will each get a 15-minute slot to talk about some of the work they've been doing and some of the learning that they have gauged throughout their work so far. So to start off, I'm going to talk a little bit about our community health profile work that we've been doing in public health for the last couple of years. And I do have a couple of polls for this webinar as well that should pop up as and when I launch them. So before we go into it, I want to just understand if anyone has used these polls before, but I can't seem to find the poll button anymore. It's disappeared on me. There we are. So I'm just going to quickly test this out and launch a quick poll to understand what our current understanding of the community health profiles are before I talk a little bit about what they are and why they're important and how they're relevant to Black History Month. So you should have had a little poll pop up on your screen. So hopefully it should just pop up and you'll be able to answer. And it should be in the chat. Yep, I can see responses coming in. I'll leave that running in the background while I kind of move on a little bit. So the Community Health Profile Programme that we've been working on for the last couple of years, they are desktop pieces of work where we compile all of the literature relevant to one community. And the main purpose of doing this is because we all know that using the acronym of BAME is not enough to identify health needs of certain communities. And we as healthcare professionals need to do better to understanding the needs of particular communities in Birmingham and how we best serve everyone. So these profiles look at specific communities of either ethnicity, country of birth, identity, sexual orientation, religious and faith communities, and we have a couple of others as well. And they're really looking at the specific mental health, physical health, lifestyle behavioural, and wider determinants of health that exist in a specific community. And they cover a whole breadth of data from getting the best start in life, where we look at fertility, we look at maternal health and experiences with maternal care, all the way through to ageing and dying, where we look at causes of mortality and we look at things like dementia. Now, the main purpose of these reports aren't just to sit on a shelf. So this is where our lovely engagement partners come in, that we need to actually use this information to enact change. So it's not good enough to just have information sitting on a shelf. So we're going to be working closely with these local grassroots organisations and community groups to actually act on some of this evidence that's found in these reports, and also to share the evidence with the community groups themselves to make sure that the evidence is reflective of the community in Birmingham, because the way evidence is collected, it's not always going to be reflective of the community experiences and lived experiences within Birmingham. So it's making it as local as possible and as relevant as possible to our communities. And the reports are shaped around the health and wellbeing strategy that you can find online. I should have a link in a couple of pages' time where you can see how the themes have been correlated to this strategy. So, for example, like protect and detect, healthy and affordable food, all link up closely to the themes within the reports. Now, the profiles that we currently have, there's 11 that are live on the City Council website at the minute. And we have, there's 15 live at the minute, or 14 live at the minute. And we have another 11 coming towards the end of this year or January 2024 of next year. So they'll be coming very soon. And so please keep an eye on that.
Yeah, so sheet coming out.
Additionally, as well, if you'd like to know when the new profiles are going to be launched, and we're also going to have launch events relevant to all of the profiles and really delve into the inequalities experience and what the next steps are there, and we can add you to our mailing list. So again, I've just circulated another poll. So if you'd like to be added to our mailing list to find out about when all of this information is going to come out, please let us know. Now, in terms of how you actually access the profiles and all of the information, they will all be on the Birmingham City Council website. You should be able to click straight onto the links within this webinar, and they should all lead you to an individual page that will have a written report, translations where it's relevant. We've got short infographics that are more snappy and useful to share like quickly and get those snippets of information. And there has been previous launch events for all three of these communities. So we've done launch events for the Somali, Caribbean and Nigerian community health profiles. I'll just quickly go through those pages. I'll leave each slide up for a couple of seconds, just so if anyone wants to access the information, they can click on it during the webinar. I assume the webinar slides will also be circulated after the conference as well, that you'll have access to all of these resources. But just give you a couple of minutes to access all of those information. And just for a quick FYI, what it will look like once you access the website is it will pop up and will give you a summary of the community health profile information if you want to pick out some key statistics, and then all of the resources will be at the bottom of the page, alongside, if there is an engagement partner, details of how to contact them as well. Just moving on. I'm just loading up the slides again real quick. Can everyone see the slides again? I can't see them now. Don't know what I've done. There we go.
Yeah.
Thank you. Okay, so for the next 5 minutes, I'm just going to quickly talk about how to use the profiles and a bit about the census update and information that we've got on the particular communities. So I briefly touched on how we've focused these reports around the health and wellbeing strategy, which is creating a bolder, healthier city. And you can see to the right a little infographic that shows all of the sections that are within the report. And to make it a little bit more easy to understand what kind of information you can get out and how it might be useful for your line of work, depending on which area of healthcare you're coming from today, is each topic is going to be divided into several relevant subsections. So for example, our Protect and Detect focuses very much on like a clinical based healthcare. So we look at screening uptake, we look at vaccination programs, sexual health, COVID-19, oral health, etc. And each other section is going to be broken up very similarly. So for example, Green and Sustainable Future covers access to green and blue spaces, experiences of air pollution, experiences of urban heat island effect, and so on and so forth. And each topic, when possible, will cover prevalence and incidence, belief and attitudes, knowledge, health literacy, service provisions, and any barriers to uptake those services. So you get a full picture of understanding what the inequality is that exists in the community, but also a little bit of context when it's available on what the barriers that community might experience and how we can support communities access better healthcare and improve health. And the reports are written in a way to try and empower change and not stigmatize change, because we all know that a lot of risky behaviors and a lot of inequalities experienced, it's very easy to point fingers and go, oh, you smoke, that's bad for your health, without understanding the underlying causes of things like that, with poor mental health, experiences of discrimination and racism, poor access to healthcare services can all contribute to all of these health and well-being factors. So it's just how can we actually use this information to better our work? So this is not a comprehensive list of everything that we can do, but these are just some of the things that we can do to take those steps. So we can use this information first and foremost just as an education tool. So being a good ally and making sure that we have that cultural awareness and competency to address healthcare in an appropriate way with, and whether it's public health or clinical setting, to be able to engage with our communities appropriately. Whether it's delivering health improvement programs or recommissioning of services or delivering face-to-face healthcare, can use that in supporting, making sure it's culturally relevant. Also using that data as a really good evidence source for advocating for more services for a particular community, and really having that evidence-backed approach, which public health is fundamentally built on. And also just using it as a tool for maybe discussing health needs with the community and helping support communities in advocating for that wider system change and helping them address the key areas when needed. All right, I'm just going to quickly do a little bit of a brief update about some of the census information, as this is one of the main tools that we've used when we're looking at these community health profiles, as it's one of the most comprehensive data sources that we have. But there are still limitations, and I'll quickly briefly touch on those as well. So we have used a lot of census information for our Caribbean, Somali and Nigerian community health profiles, either looking at ethnic group or country of birth. Obviously, some of the limitations of doing country of birth data that we need to consider is it's not going to cover an entire community. So it's only going to cover first generation migrants, and it's not going to be representative of everyone. But the data source is kind of one of the best we have, but it's not going to be the be all end all. So it's a good starting point. And it's also really important to consider that some of the communities may cross-identify, and there's aspects of intersectionality. So although someone may identify ethnically in one way, their country of birth could be different and will influence their health in a whole variety of ways. Some of the main data that we can pick out from the census, which is really useful either to look into the community health profiles or to look online on the census tool, which I think I've put a link in. If not, I'll pop it in the chat. And you can get information on geography, so you can understand where your population is if you want to do place-based approaches. We can understand a bit about demographics, so the age of a community, the country of birth, year of migration, and get a little bit of understanding of some of their experiences. There are some other characteristics, so things like language, first language, English proficiency, national identity and religion, which could help shape how we communicate information out. And then there's more wider determinant data, so things on highest level of qualification, occupation, health, housing, etc. There's a whole host of information that the census can give us. And just a quick overview, because I'm cautious, I'm going to run over my time slot in a minute, of just some of the key stats that we've pulled out about the Somali, Caribbean and Nigerian engaged communities just from the census. So it gives us a brief overview of population. And if any of you are from some of these communities, you may think that that's an underestimate. And as I talked about with some of those limitations, a lot of these numbers are going to be underestimates, and we can work on building those better data sources in the future. A quick tool that we've created that is useful for having a quick overview of this census data is we've created some census infographics that are also available on those links from the previous slides. They're 4 or 5 pages long and cover those really key headlines, really visual, really useful to share with that. So trying to keep to time, I'm going to move on and let the engagement partners have their time to shine. So I'm going to call on Nemo first, who is our Somali engagement partner, to talk a little bit about the work they've been doing and who they are at SOS Education.
Thank you, Jordan. Hello, everyone. I do apologize, but my camera isn't working, so I'm just going to carry on. Okay, so I'm Nemo Hersey, the health partner for the Somali community health profile. I work for an organization called SOS Education Organization Limited. We're based in Bosley Green towards Digbeth. We are in a center called the Garrison Center, and the Garrison Center has a nursery on site, community center on site, homework club in the afternoons, mainly English classes. There's a fair bit that goes on. Support for autism, there's a fair bit that goes on. So the bit that involves the Somali community health profile that we are the partner for is that so we won the bid to be the partner, and two jobs we have. Our main 2 jobs are to disseminate the profile to the community and all stakeholders, and 2, to feedback, improve with insight from a community point of view. The profile highlights the inequalities faced by the Somalis in general, but within Birmingham. And those are in education, housing, health, maternity, and so on. So in education, and the reason why we applied for this is because my background is in education. It's mainly underachievement, and I suppose we share this with other ethnic minority groups. Underachievement, a high level of exclusion, and we wanted to get to the bottom of it. Housing, in terms of housing, it is overcrowdedness. We all know that, you know, Birmingham City Council don't have a big stock of houses to offer people, so therefore there's a big level of overcrowdedness, which then affects everything else. It affects health, it affects mental health, it affects your education. If you have nowhere to do your homework, then you know, it becomes difficult. Health, yes, especially mental health and maternity, the inequalities are fairly rampant. So what we have done so far is disseminating, first of all, the profile, because when we got the contract, not a single person that I speak to knew about the profile. So one of our jobs was to make sure that we scream high and shy and people are aware of the profile. The profile has its faults, but it's a good place to start at highlighting the inequalities faced by this particular group. So what we did was we held workshops. We go around every pretty much any gathering that's going on. I'll take the profile with me and I will show it to people. Are you guys aware of this? And if they say no, I'll say a few words about it. And people are curious, they'll go straight away. They'll go on Google, Mr. Google, our best friend, and they will hopefully read a little bit about it and know more. Some are more interested than others. Some are saying, well, it doesn't represent us because there's no, you know, I don't know, they're looking at the pictures. I did that, to be fair. I'm guilty of that. Look at the pictures and I go, these don't look like Somali people. But it's a good start, and hopefully, you know, when the next round comes, whenever the next round comes, hopefully it'll be you know, it will have things that we've added onto it with the insight. So that's what we do. We disseminate it. Some of the workshops we've been running are with the NHS. So for example, we did a really big workshop called the listening session with the NHS, and in particular the maternity. And as a result of that, to be fair, a report got written and some of the implementation, and I was very, very happy with this, is that already statutory bodies such as, you know, hospitals or GPs are contacting us and saying, okay, so you've said to us that my community will not read because of the English barriers, and they will not read even if you write it in Somali because of the literacy barriers. So now what we said was, okay, but if you have a podcast, people will listen. So now what we're trying to do, we're a long way away, but we've started to do is to record voiceover on, for example, a little video about healthy eating, or one on diabetes, or one on whatever the healthcare situation may be. So we would re-record it, voice over it in Somali, and people will then, whether they're in their GPs and sitting in reception or at the hospital, they'll then listen and hopefully get a better understanding of how to look after themselves, because obviously prevention is better than cure. So that's one of the things that have already been implemented. Another thing that, as a result of the workshops, came about, and we have a coffee morning every Tuesday. So we had one yesterday actually. We had 3 young ladies from the University City Birmingham, who are all final year of universities, coming and actually talking to the community and getting first-hand experience of, as and where they graduate, you know, how to approach their patients or their future patients of Somali origin, and how the two, because at the end of the day, prejudice works both ways, or lack of knowledge of a particular culture works both ways. So it's us, the community, saying, okay, well, if this particular nurse is taking care of me, but she's not from the same culture as me, how do I behave? And if this nurse, if I am the nurse and I am taking care of my patient, and they are of this particular culture, what do I know about this culture? How can I make them comfortable? So the point was that, and we had a really good session yesterday where the 3 students left and they were very happy. The mothers were very happy because they got to talk about their experiences in a comfortable environment. So that's one of the ways that we're doing. Another thing that we're doing is we are subtitling a movie in Somali. The whole thing is in Somali, the actors, everything, but we're subtitling it in English, and we're hoping that one of the professionals and anybody else who's interested would be able to, you know, view it and use it so that they can get a better understanding of the mental health. This one is in particular about mental health within the Somali community and the taboos around it. Another thing we're doing is we're doing a bit of data collection around exclusion and Somali kids within schools, because that's a very high rate, and underachievement and underachievement in schools of, again, the Somali pupils. So there's a fair bit that we're doing. I don't know how much of my time I took, but I'm gonna stop there and I'm gonna see if there's any questions.
If anyone wants to ask questions, there should either be a Q&A feature, or put it in the chat, or if you want to speak out loud, happy for anything. And Nemo, someone's just asked if you can share the mental health video.
Okay, it would help if I unmute myself before I start talking. And it will be once it's finished, it'll be on the website, the Be Bold Healthier Birmingham website, and as well as on our, at the moment the website is under construction, but we have a Facebook page, SOS Education Limited, where we put all of our progress. It will be on there as well.
Once the next presentation started, it might be worth if you pop your social media link in the chat, and then people can find you a bit easier.
Will do.
Perfect. So we've had one question just saying, love the movie project. Are members of your project involved in the filming?
No, because actually the movie is almost 5 years old. So it was produced a while back, but we're only subtitling it at the moment. So we are leaving it as it is because I think it's such a powerful message, and the messages are very layered. And so we're doing nothing else with it. We don't want to interfere with it. We're just literally subtitling it in English. And that's what we're doing.
I think final question before we move on is, someone has asked, how do you support drug users in the community? I'm assuming the question meant about the Somali community.
While responding to the profile, to be fair, we haven't had to, but in general, and we talk about drug use and abuse a lot within our sessions. the first thing being that it's quite a taboo area because you're a Muslim. How could you be taking drugs? Well, we are, and we know that we are. Some of us are. Right. So what I always say is, and then again, on top of that, so, okay, so there's this thing that, oh, if you're a Muslim, you shouldn't be taking drugs. But then there's another thing where families of people who use drugs, or then that we have this horrendous culture called, we were talking about it again yesterday, it's called, well, now that you're a user, you are no longer my son, or you're no longer my daughter, or you're no longer my mother. It's disowning, that's the word I'm looking for. So you disown, and it is horrendous because that's un-Islamic, that's inhumane, and we are trying to just make sure that people understand that we're human beings, okay? Things are going to happen. And so it's how you deal with it that's important, how welcoming you are, how understanding you are. Do you understand the reasons why this person got into abusing, not just using, but abusing the substances? Could it be 100%? I am certain that anyone is because they didn't get help. They didn't get early help. Do you know? So that's what I say. I say to them, listen, if my own son, my own daughter was using or abusing, I would be the first person to welcome them, to hug them, to go look for help, not disown. So that's one thing. If there's one thing that we could do, if I could erase it today, take an eraser and erase it, I would. But if we could make people understand that that's not the right way to go about, that's what we're trying to do. We're literally trying to raise awareness because it's multi-layered. It's multi-layered. So, but every little helps.
Right, just going to power through the next couple of questions. I can see there's a couple of hands up. Lysandra, I can see your hand was up first. Do you want to come in quickly? And then Nemo will try and power through for another minute.
Hi, thank you. I did ask a question. I work for Change Where I Live, and I think someone's put the information in the chat. Part of the work that we do is supporting underrepresented groups. I call it need to reach groups. And perhaps I'll put my email in the chat, and we can kind of do some joint working. We work nationally, myself and my colleague who's on here today, but we can actually do some work to support, or trying to support different communities so they can come into treatment and understand the need to come into treatment, and also do some training around the community so they can understand why getting support for substance is important as well.
Brilliant. Yeah, thank you. Please do share details and we can share them all around.
Thank you.
Candice, you have your hand up as well.
Sorry, that took me a second to unmute. Yes, it's very much similar to CGL. I work for the addictions team within Birmingham City Council, and just wanted to kind of pick up a call with her offline, and that was to just make sure that the communities have the educational resources. One of our providers is CGL, so it's the same thing. I'll probably speak to you in communities and then get contact. Thank you.
Yeah, brilliant. We can put you in touch. And then we've got one more question in the chat quickly. I think we've got a couple of seconds that we can focus on it. So Nemo, the question is, I learned about the chewing of cat in a training last year. Any interventions specifically around that? So if you want to come and speak a little bit about cat.
Oh, that's a good question. So we know that cat was actually outlawed in the country some 8 years ago. Still there is plenty of cat coming through. Well, plenty, I'd say some coming through, you know, illegally. It is a substance that can create dependency. It is the one, actually, funnily enough, the one substance that people don't actually see as a drug. It's more like a recreational, because it's fairly cultural. So back home, it's actually seen not as a substance that people can misuse. So we do want to support, but because of it's been outlawed, that therefore it's gone underground, it's very difficult to then support the person with. But it is a substance like all other, and you would deal with it in pretty much the same way.
Brilliant. Thank you so much.
I don't know
for
if that
that,
answers
Nemo.
the question.
I think someone else has put some more information in the chat as well, which is really appreciated. But thank you, Nemo, so much for that. We'll move on just so we've got time to cover everyone's presentations. But if there's any more questions relating specifically about the Somali community or the work they've been doing, please pop it in the chat or the Q&A. And if we've got time at the end, we can go over some more. So moving on now to Michael taking the lead.
Great, thanks very much for that. There we go. MindsEye Development. So we're a small social enterprise based in Birmingham. I'm going to put my email address in the chat rather than consume too much time on this. But our strap line is empower, collaborate, and connect, and that's really what we've been trying to do through this particular program. And if you can just move it on. What this particular program has given us the opportunity to do is not just to raise awareness, but also to look at how we can work with communities to innovate, to pilot, and to co-design activities. And I'm going to be speaking to you about the Memory Cafe, which is focusing on dementia. But I just want to take a moment just to mention the two others that we're looking at, being mental health, where we're looking at we've been working with a men's group looking at a particular slant, a particular dimension of mental health that we think is not being fully acknowledged and addressed. And we've been looking at that, and we're starting to work with a group of women on some particular mental health issues as well. And the maternity support is the one I kind of wanted to focus on, simply because I just want to draw to your attention that, like Nemo has just been mentioning, we've also been speaking with women around their experiences on mental health. And if I can just give you a little plug on this, we've got an event coming up. I don't know how to put an attachment in the chat, but we'll work it out. So we've got an event coming up on the 19th of October, where we will be discussing these issues with representatives from the ICS, the Integrated Care System. But what I want to do is to go back to the Memory Cafe and to focus on that and to illustrate one of the things that we've been putting a lot of energy into. And if I can just start by just giving you some data, because the Memory Cafe is about addressing dementia. And so before I do that, I just want to give you a little bit of a snapshot about dementia within Caribbean communities, which is it's 25% higher for Black women and men than it is for white women and men in the incidence of dementia. It's the most common cause of death for Black men and actually for Black women. This data, you'll find this data in the community health profile. And the community health profile also says that dementia is misunderstood and highly stigmatized. And it calls for a vision of a culturally appropriate approach to a dementia pathway that starts with raising awareness, leads to facilitating early diagnosis, and lasts into appropriate end-of-life care. And that's a theme that's also present and repeated in the ICS strategy, and they go a little bit further to acknowledge health inequalities, and that within certain communities, the challenge that they will face is in providing culturally appropriate services. And if you like, that's a segue into what we're trying to do, which is to look at culturally appropriate provision of support for people experiencing dementia and their carers. And on this note, I'd like to introduce the partner who we're working with, who's Dawn Carr. She's on the call, and I'm going to be putting some questions to Dawn so that she can explain what this pilot is, how it's working, and what we're trying to achieve through that. So I hope you're there, Dawn.
Yes, I'm here. Thank you.
Great. Thanks very much. So Dawn, tell us about the Memory Cafe, or share with the audience the Memory Cafe in terms of why we've set it up, what we're trying to achieve, and in particular, what is unique about it and why.
Okay, let me just start by saying and just clarifying that dementia is as a result of the decline of memory cells within the brain. And that can occur as a result of many different factors. And vascular dementia is one of the most common types of dementia that we know in terms of the increase of dementia globally. This is not just within the UK. And you said earlier on that 25% of those are higher within the Black community as opposed to white communities. But one thing you didn't mention is that usually dementia is like a normal occurrence. It happens with old age, but we're finding that people from a Black community are getting dementia a lot more earlier. The usual age is around 65, but I'm seeing people 45, 55 who are showing early signs of dementia. And this can be a result of this increase in vascular dementia, of which we do have some control over. The other thing I wanted to note is that even though somebody has dementia and they're showing behaviours that may be different to the person that they were before, they are still the same person. So the most important thing is that somebody is treated like a person, that you don't dismiss them, that they're not worthy of care and support, and that they live well with dementia. And the reason why I say that, that's the reason why we have a memory cafe, so that people with early signs of dementia, or still suffering from the challenges of dementia, can live well with dementia. Now, what's unique about us is that we provide a culturally sensitive approach to a memory cafe. The memory cafe is not a new idea. There are agencies like the Alzheimer's Society who have been providing wonderful care for people with dementia. However, when you're dealing with somebody of colour, especially here in the UK, we have a very short period of settlement in the UK. So within their memory recall, their memory recall may take them back to a time of their motherland or early settlement within the UK. And for those who are caring for them, whether it's family members, whether it's health professionals and care staff, they need to understand that memory recall may be from their cultural background, where they come from. So it's important to have staff members, volunteers, and people around them that can stimulate that memory recall so that they can live well with dementia. So what we find with a culturally sensitive approach is about making sure that all the brain stimulating activities and health and wellbeing activities are culturally appropriate for those who are attending. So, for example, a jigsaw puzzle should be an image that they recognise from their past. A word search should be words that they from memories of their past, and they could be words related to their Caribbean, African, or whatever background they come from. Also, within the process of a memory cafe, it's about networking, it's about having fun, it's as I said, living well with dementia. So activities may include sing-alongs, and those sing-along activities should be culturally appropriate, have songs that they remember from their own background, from their own experiences, from the country that they came from. In addition, the food that's provided should be culturally sensitive, and we also do a lot of reminiscence activities where we have discussions about things that could appear in their memories, and these could be reminiscence activities again that reflect their journey to England, or maybe even further, you know, at home in their motherland. So I hope I'm building a picture here in terms of why it's important and why we're unique. And what is also unique about the work that we do is the health and well-being activities, i.e., if we do yoga, it's kinetic yoga. If we're doing, health and well-being activities, they're all complementary and are culturally specific as well. You're on mute.
I know that there is advice and guidance from the Alzheimer's Society suggesting that people should try to look after heart health, look after brain health, and they suggest staying socially active, challenging your brain regularly, looking after your heart health. And I mean, I've visited the Memory Cafe, and I've spoken to people and I've heard what they say. But what is their feedback to you, Dawn? And what are we learning?
Yeah, I mean, I visited as well, and I've seen people's change in mood, behavior. I've seen them come out of their shell and be a lot more engaging. They've really appreciated the activities. They seem happy and healthy. And the feedback that we're getting from the users and their carers is that they welcome the access to information and support, but also what I didn't mention is that we have a rolling programme of health professionals who visit our memory cafes. So we've had speech therapists, we've had nurses, we're doing a blood pressure campaign because hypertension is an important factor in early diagnosis. Physiotherapists have joined and did sessions, and they've enjoyed actually having that exposure to a wide range of health professionals and also the information that comes from those health professionals.
Yeah. Now, Dawn, the reality is that this programme, the pilot that you're delivering, that's funded through our budget for the community health profile. So inevitably, that's going to come to an end quite soon. So just in terms of sustainability, how can our learning be made sustainable? The conversations that we've been having, what are the highlights of those conversations for you?
It's funny because everybody seems to be benefiting from our memory cafe, whether it's the users, the carers, or whether it's the health professionals that we've called in to engage with it. So what we've done, we've collected all of that. So we're going to build a form of a toolkit. I hate to use the word toolkit because it's bandied around, but it's guidance for whether you're an actual person who's got the challenges with dementia from a particular background, or those who are caring for them, or the health professionals who are learning all the way through this journey, so that we can signpost those who have challenges, but also this guidance can be the blueprint for other communities. And I think that's the most important point. What we've learned from this is that other communities can take this model, whether you're from the Asian community, the Irish community, the Polish or community. We're here talking about health inequalities, and we've identified obviously the most prominent health inequalities, but it goes across the board in Birmingham. And what we found is that this resource, the learning that we've had from it, could benefit all communities.
Thanks very much for that, Dawn. And just to say, because the approach that we've been taking to this is about piloting a way of working, and it's about trying to develop a model that can be rolled out in the way that Dawn has said. So, as part of our remit with it, through the community health profile, we've also been engaging with policymakers. So we've been having conversations quite recently with people from the ICS, from within public health, and our aim is to say at the end of this, here we have an evidence-based model that works, an evidence-based model that, as Dawn has said, is transferable, and some of it is even transferable, as we've been told, beyond dementia into wider fields of frailty. So that's us. That's an example of what we're doing. I'll put my contact details in the chat. I'll put the flyer in the chat. Feel free to reach out to us.
Thank you so much, Michael and Dawn. Sounds brilliant. I think in the nature of time, if you've got any questions for Michael and Dawn, can you please pop them in the chat, just so we've got time to do all the presentations, and we'll come back to all the questions after Heather. Thank you both again. And our final speaker of the day, let me introduce Heather.
Hello, everybody. Well, so the Refugee and Migrant Centre, who got the contract to disseminate the health profile for Nigerians, was established in 1999 in Wolverhampton, and since then we have offices across the Black Country in Walsall, Dudley and Wolverhampton, but also in Birmingham in the last 5 or 6 years. And we're situated in the Jewellery Quarter, right in the middle there. In fact, we have 3 offices on that site because we're increasingly having to increase our capacity all the time. So we support around 14,000 refugees and other migrants each year across the Black Country. And Birmingham. We provide a holistic drop-in service to support clients overcome barriers to settlement. So that includes everything from housing, destitution, accommodation, health, employment, education, training, but most of all immigration, because that's what is the biggest barrier of all to migrants accessing any equality and to their settling in the country. The services we have, as I say, immigration, OISC accredited. You have to be OISC accredited to be able to deliver immigration advice. It's holistic wraparound service, health, employability projects, and we're mostly user-led. And we can deliver our service in 45 user languages that are available on site. If you could go to the next slide, please. Thank you. The reason that the method we used was, the purpose was to get that health profile out to Nigerians, and we had access to a lot of Nigerians on our database at work, and then get their feedback on it, and did it reflect their reality, and why did they think that inequality existed? And then for them to generate some solutions. We felt it was important that we were just observers, we were recorders and facilitators, but it was they that were leading the show, basically. So out of their health profile, we shared the whole, well, the infographic with them, but we came down on 3 particular topics. One was the stillbirth rate, which is double for Nigerian women in Birmingham. Which is, in fact, is more than double the average in Birmingham. We also looked at domestic violence. The evidence on that was a little bit thin in the health profile, but it gave us an opportunity to talk about domestic violence, which I think is always a good thing wherever you are. And we also looked at what was described in the health profile as hesitancy around vaccination and immunisation, not only COVID and childhood immunisations, but the adult immunisations as well. So those were the 3 topics that we focused on. Next slide, please. So 105 Nigerians from Birmingham attended, and we did a set of 3 sessions was the aim when we were first delivering this. And the 3 sessions were a sharing session where we shared the health profile, then a listening session when we listened to them, and then a planning session about where are we going to go from here? What are the solutions we can come up with? Who do we need to tell about this? So in the end, we had 20 face-to-face 2-hour sessions. We circulated nearly 1,500 copies of the Nigerian profile, both online to our clients, and also anybody who attended our sessions got given 10 copies, and we asked them to disseminate those, and they did, because they came back and told us about it. And about 184 separate attendances were at our sessions. The emerging themes out of that were as causes for the health inequalities were, first of all, the impact of the asylum and migration system. If you're an undocumented person in this country, and by the way, one of the comments that came out consistently from it was that the health profile didn't actually reflect the true number of Nigerians in Birmingham. It was just a tip of the iceberg, especially if you took into account those people without documentation. And people without documentation, of course, have access difficulties anyway. They cannot access secondary healthcare. But they'll also have other issues around accessing primary healthcare. So if you look at that impact on people's mental health of the whole system, that's a massive contributor to mental health, physical health, and to the health inequalities data. The second one was a lack of knowledge about the UK health system, how it works. They didn't realise what was normal. So if you're pregnant, they didn't necessarily know that they should be attending antenatal classes, or why they should be attending them, or what the benefits of attending them were. So a lack of knowledge. No one ever told us this. No one ever told us this was what we should do. The third one was around accessing primary care, and actually those comments under that really reflected the things that we all experience. An Indigenous white female like me experiences with accessing primary care, but added to by a lot of other things that were specific to not only Nigerians but most of the other minority groups. Experiences of racism were, and lots of stories around that, lots of case histories about that. A definite feeling that racism is an issue across health services, and not only health services. And then the issues of culture, and I guess this is the same with most of these groups that we're talking about. You don't just leave one culture and then take up another culture. You come from one culture, you don't leave it behind, you come over to this country, you're still reliant on that culture in your home country. You still might live within that culture in this country, but then you're also in the tensions of living in the UK culture. And that really came to the light when we were talking about domestic violence, and how the culture in Nigeria is that the husband is in charge. Like they talk about what was the phrase they used? The Lord. And then you come to this country and you find that's not the norm. But it's very difficult for both the male and the female to adapt to that change. So it's very a complex issue. And then finally, language. Now everybody in this country, I suppose, thinks that Nigerians speak English, and many do, but not only do we have to talk about, as somebody earlier spoke about, people who are illiterate in their home language, which is quite common, but people who their English is at the level of what they call of pidgin English, and therefore they won't understand necessarily somebody talking to them about, or a piece of literature given to them about, say, maternity services. So one of the appeals was that we look at producing stuff in pidgin English for them. Next slide, please. So these were the things that they came up with as suggestions, because this was, the result of our listening and our recording, and then I would check back with them at the next session. Is this what you really want me to say? Does this reflect the truth? And they would amend that accordingly. So the first thing they said, they thought we needed more research into Nigerian health in UK and Birmingham specifically. That the health profile was, as somebody said, a good start, but it needed more in-depth looking at it, and perhaps some research to be initiated into it in more depth. Secondly, to focus on raising the awareness of new arrivals and how the NHS works, what their rights and responsibilities are, what to expect, for example, around maternity services, immunisations, etc. What is the normal provision in the UK? They didn't know that, and therefore they're unlikely to access it. To produce multimedia messages around health issues and available services, including in pidgin English, which was mentioned, and to reach out with information training to places of worship. That was one thing that they said. Places of worship are remarkable places where they can gather. They couldn't, while they were at normal, worship, they couldn't discuss these issues. It wasn't appropriate, especially when you talk about domestic violence. It wasn't appropriate to raise those. Probably not advisable. Whereas if they could, but you could. If you wanted to share, for instance, immunisation information or any specific topic, rights around, your rights around maternity, this sort of thing could be disseminated in places of worship. And they wanted you to train and monitor professionals in active listening skills. and in good customer service and in patient eligibility, particularly associated with migration status. So they wanted to feel that people were listening to them. And they weren't just, it wasn't just you know, an automatic sort of response, that people understood them. And good customer service, they felt that customer service was not good enough. It wasn't respectful. There were lots of, oh, hang on, can we go back one? There was a lot of disrespect and a lot of lack of understanding, and that also they need to know that professionals need to know about patient eligibility. Lots of professionals, I'm sad to say, because we've been working on this for about 20 years or more, lots of GPs, they are still being asked for ID, for photo identification, this sort of thing, or being refused registration at GPs. Also, there's a lack of knowledge between different eligibilities amongst migrants. So everybody's eligible for GP registration. So it doesn't matter who they are. But there's lots of ignorance around amongst health professionals about who's eligible for what, because there is some variety there. Sorry, next screen, please. They said use Nigerian community members in the NHS to deliver messages, information. 25%, according to their health profile, 25% of overseas nationals in the health service are Nigerian. So there's surely a lot of those people about. It's much better for a Nigerian to be talking to Nigerians about, you know, getting your child immunised. Though that wasn't an that was one of the things they rejected. There is no issue in Nigeria around childhood immunisation because they've had it for generations and they've been immunised. Their parents have been immunised and their children were immunised. But there was issues around other vaccinations. Where was I? Yeah, one of the biggest things they wanted was to facilitate a Nigerian community hub in Birmingham. There is no dedicated space for Nigerians to meet in Birmingham. In fact, it got that we'd have, you know, up to 20 Nigerians in one of these sessions, and we couldn't empty the room for the next session that we've got to do coming in because they wanted to stop and chat to each other. In the end, they formed their own WhatsApp group. And that's still active, and they're sharing all sorts of information around that. So that was what seemed to us like a simple remedy. And to give proper explanations and any requested information to patients around what and why treatment is given. It's no good, as some woman was telling us in one of the sessions, I asked about the COVID vaccination, why did I need it? And they said, because it's good for you. That isn't good enough. These people have got the same intelligence as you and I, and they need proper explanations. And if you ask for an explanation, it's good because it's good for you, is not good enough. And then to encourage men and boys to be included in health matters, particularly around maternity. And they suggested this could be done via schools, places of worship and community centres. Thank you. Next slide. So these were some of the suggestions that we summarised with their agreement at the end of it. And they came down to local system change and government legislation change. I should just say here before this, with the solutions that they came up with, one was we don't know about these things, as I said. And so one of the things they didn't know about was how the health system works. One of the things they didn't know about what their rights were around maternity. And the other one was that we didn't know what was normal around immunisation and vaccination. So we trialled a session, a 20-minute session on that within those sessions. And then with the approval of the Nigerian community members, we ran that as a standalone pilot. And they were run quite successfully and people were keen to come to them and got good feedback for each of those. So if nothing else went forward, to carry on with those sorts of sessions to raise awareness across the community would be good. So the other suggestions that we made, so it's locally hold open drop-in clinics for anti-postnatal and immunisation. The women were saying that in Nigeria, there would be an afternoon dedicated to antenatal and you just rocked up at that antenatal. You just turned up there and you were seen. Whereas here, you know, you get a very, very specific appointment and no choice. And, you know, if you're not there at 3:05 for that appointment, you're likely to miss it. So they weren't used to that sort of, and they felt it would be much more helpful if we could have more open clinics where people dropped in, and similarly for immunisation. Give choice of 2 or more appointments. You know, if you can't come at 3:10 on Thursday, please can you come at 11:30 on Monday, which gave people much more choice. And these were all very, very busy people involved in, you know, sometimes 1 and 2 jobs and bringing up children, and all that made them very busy. But to be able to only give them 1 appointment was very difficult. And then wouldn't we all like this, to improve the GP appointment system? They felt that was really, really difficult. What would require sort of government legislation change would be to give joining spouses independent immigration status. The current system of immigration is that if a man, or indeed a woman, gets immigration status, gets refugee status in this country after seeking asylum, they get their status, they can then apply for family reunion. That partner then joins on a spouse visa. The trouble is that spouse visa is dependent on the spouse. So, and although if a relationship splits up, we can put in an application for the spouse to get independent status. It's often used as a threat to the spouse, to the joining spouse, and so that reinforces the possibilities of domestic violence. So that would be one big help. And a lot of people talked about the mental health issues around that and the incidence of domestic violence. Allow all migrants to access secondary healthcare free of charge. At the moment, migrants who don't have documentation cannot access hospital care. They will only get treatment from a hospital if it's for an immediately life-threatening reason. And when I say immediately life-threatening, that does not include radiotherapy or chemotherapy. So it has to be immediate life. Somebody has to be bleeding to death. They will then get that treatment. They will also be charged for it afterwards. So that is a huge and massive cause of inequalities to people in Birmingham. And then the third one would be to allow all asylum seekers to work, because the pressure of being an asylum seeker, not only are you in financial destitution, you have no right to work, or in very exceptional circumstances, and so you know, there's no occupation. You could be an asylum seeker for 2, 3. I've known somebody being an asylum seeker for 11 years. Imagine that, not being able to work, having to stay in the accommodation you're provided with, being separated for many years from your loved ones, and all that impacts on you. The big relief to that would be allowing them to work, and it works in other systems, so that would be good. Next one, please. So we said as the first steps would be the facilitation of a Nigerian community centre in Birmingham, probably be the most effective first move, that given that 25% of Africans who work in the NHS are from Nigeria. As an example, that these are capable people who know what they need and know how to get it. The Nigerians participating in these sessions generated these solutions themselves. So if they can do it with me, they can do it within their own community centre. And that the skills and capacity to bring this to fruition with a little support are already in place. It would seem a good place to start. Thank you. And these are just some of the quotes. I guess these will get circulated. Some of the things that were said about it's depressing having to wait for eternity before getting an appointment for asylum interview. You live in fear and depression. There is no hope of those people achieving health equality when they're under that such severe mental health strain. If you're not legal, people suffer in silence. They delay going to hospital, especially if you're pregnant. You're not going to rock up at a hospital if you're going to get a £6,000 bill for delivering your baby. You will go because you'll be forced to in the end, but you'll delay going because you wouldn't be paying for antenatal appointments and things like that. So you don't necessarily know what the charging system is either. People who are asylum seekers have not gone to deliver in hospital because they think they will be charged, because they know that their friend got charged because that person doesn't have status. So there's lots of, I won't go read all those out, but there's lots of stuff there. And one of them was about the lady who was told in maternity in a Birmingham hospital that you don't need pain relief, Nigerian women are strong. So this is one of the examples that we gave. I think that's the last slide. There might be one more slide, or is that it?
I think that's the last slide. So thank you very much, Heather.
Thank you very much.
Thank you to everyone that's presented today. I think it's really important to kind of kind of draw attention to some of those statistics. And as all three of you have kind of highlighted, the community health profile can only tell us so much. The data is only as good as the research that's out there, and that's why the work that all of you are doing is so important, to actually make sure that the data we're using to inform all of these practices is relevant and actually appropriate for all of the communities that we're working with. So I appreciate that we ran over a little bit, so thank you to everyone who's still with us. And I think now, if Michael and Heather, you're right to stay on to take some questions, we'll see if anyone has a couple of questions. So can we start with any questions for Michael regarding the Caribbean Community Health Profile or the work that they're doing with the Dementia Cafe? Again, either put it in the chat, put your hand up, or use the Q&A.
Use the Q&A. Use the Q&A.
Rose, yeah.
Hello. Firstly, thank you very much for such an insightful information session. I've enjoyed it. With the Dementia Cafe, how widely known is this initiative within the Caribbean community in Birmingham? I have heard of one person I know visiting Dementia Cafe and did benefit from it greatly, but I haven't met anybody within that diaspora that knows of its existence. Do you link with local communities via churches or in any other way?
Okay, let me answer. I have to say I'm not surprised that it's not so well known. It was a short program that we've been delivering. We knew that it was going to be a finite program, and one of the things that we found out as well was that despite the fact that we've got good knowledge and good networks, it still takes time to give individuals and families the confidence to actually come to a centre, particularly if they're coming to an area that they don't already know. So it's not Birmingham wide. It's located on the west side of Birmingham, Dudley Road. So its catchment area is going to be quite finite. So yes, I mean, the points that you make about knowledge and reach, I completely accept.
Thank you, Rose. If there are any more questions for Michael, if not, we can move on to some questions for Heather and the Nigerian engagement partner work. Oh, there's one question that's for all the speakers. Are there gender-related differences in attitudes to accessing healthcare? So either for Michael or Heather to answer that one.
Certainly, we have seen some. So for example, we work with different men's groups, focus on issues, whether it be like diabetes, blood pressure, prostate cancer, and this topic comes up regularly. And I was at an event a couple of weeks ago, and there's a guest speaker, and the guest speaker at this event, in talking about prostate cancer, he said that black men are dying from two things, and he said fear and ignorance. Yeah, and it's like fear and ignorance to go and get medical assistance. I'm not saying that that's everyone, right? But there certainly are issues about access, and some of those issues may relate to the individuals, but to be honest, some of them relate to experiences that they've had previously. And this came up particularly when we were talking to women about their experience of maternity services. It's prior experiences impact on their attitudes towards going for medical care.
There certainly were gender differences amongst the Nigerians we spoke to regards, for instance, maternity. Maternity was definitely just a woman's matter, and men didn't get involved at any stage. The only, I remember one comment from one of, we had almost equal quantities of men and women at the sessions, and one of the men said he knew nothing about stillbirth, didn't really know what stillbirth was, because he hadn't been involved in maternity at any stage, and they were quite shocked to find that one of our Nigerian staff members had been present at the birth of his children. So there were differences in that way, and of course around gender abuse and different roles for males and females in Nigeria, and how that impacted on their lives here. So yeah, there were gender differences. Hearing Mike just talk about prostate cancer, that was one of the really good things that came out of the health profile. Men didn't know about prostate cancer, and we were able to raise that and disseminate some of that information about it. One of the most preventable of cancers, and yet they knew nothing about it, and what a big killer it is amongst Nigerians. So yeah, and whilst I'm just on, I'd just like to say that all of the people who attended the sessions were extremely grateful to the City Council for producing the health profile. They felt it was a really good step forward and a really good beginning. Thank you.
Thank you both. It looks like we have a hand raised from Adewale. I think Rosie's is still just a hand up from before, unless Rosie have something else to say before we move on.
I've actually tried to lower it, but I can't, to be fair.
Oh, there we go. It's gone.
Thank you.
All right. So it's Adewale next.
Hello. Yes. Yeah. Adewale. Yes. It's a question about the Nigerian community profile and health issues, and I just wondered. I was going to ask a question about the men actually as well, but you've kind of answered that question, Heather, in terms of reaching out to men more and what you are doing, especially around prostate cancer actually, and other health issues, including gender issues, women, and the like, and in the fact that Nigerian men are quite involved in family issues in the home, but the lack of awareness of women issues, and that may be their daughters, their sisters, or fellow migrants who are women who may need support within the community. So it'd be good to get more awareness of health issues affecting women within men actually, as well as obviously men as well. The only thing I was going to ask is, in Birmingham, we do know as well that there are a lot of young students, a lot of university students or college students who are from Nigerian background, coming into Birmingham from Nigeria. But maybe, I know there's quite a large student community in Aston University in Birmingham, and I wondered what sort of awareness they're getting around registration for GP. So a lot of them will be mature students as well, who may be in the country with their dependents and studying. So I wondered what kind of outreach work you're doing with them, with that student community as well. Thanks.
Thank you for that. Yeah, lots of interesting stuff there. We did have some university students on the sessions, because mostly we recruited from our own database, but we also circulated loads of other Nigerian places of worship, even shops, restaurants, that sort of thing, and universities, and then it snowballed from there. So people who attended sessions then snowballed out the invitations to come. So we had fairly good reach, and we had fairly good representation across ages and gender. As I said, nearly as many men as women, very close, I think it was. Regards reaching out, we're there to support. We have our health projects at RMC, and we're there. We will support with any primary care registration, any access to secondary care. We're often challenging, secondary healthcare charging, that sort of thing. Anything around health we can support with. We've got dedicated health workers at each of our offices. Unfortunately, we're restricted by funding, so we are purely project funded, and other people on the call will understand this, that we can only do what we're paid to do, because otherwise if we're doing stuff we're not paid to do, we're stealing from the people who are paying us to do the projects we are paid to do. So so it's great to get this funding to do this. There's loads to be done out there, but we can't do it without that funding. I know everybody understands that, but it's that's the issue around getting the message out there. And I suppose it is for all organisations, the council and whatever, that you need the funds to do it. They don't just happen without funding those things. I hope that answers your question. I'm not sure.
Yeah, it does. Thanks very much. I suppose you probably would work, in partnership with the council, because the information, getting information out there for people is really important as well. So obviously, if it's not within your direct remit, it might be a case of kind of collaborating, perhaps, to sort of provide that information that you have, which is quite useful. Thank you.
Thank you.
Thank you. I think we'll take one more question for the webinar and then we'll close up. So I can see there's one more hand from Gail.
Hi, yeah, it was not really a question, also just to say that I'm Bump, NHS Birmingham Women's, and we work with pregnant women through their maternity journey, and it's particularly from ethnic minorities and everything, just to help with that journey, where there will be a language barrier and them understanding the journey through their pregnancy and just making it easier, and when there are any crisis with immigration housing. So it's just to basically say that there is a service there that women can access, and I don't know if there's a thing where we could link with Heather and Michael regarding that, and just to work together with that, to that the women know that those services are out there that they can access through the maternity, to understand that journey, and just to help them. But we can attend appointments with them, on them to understand the appointments that are coming up, just things like that around their maternity, just to make that awareness, so that it is actually there is a service.
Yeah, that's great, and we're aware of similar services elsewhere, and we get the information out to people. If we've got the information, we'll share it with anybody. My email is in the chat if you want to send me your details, and then I can pass that to our health caseworker. She might already know about it, I'm not sure. We've certainly worked closely. We've got clinic rooms at all of our sites. We've even had midwife clinics and health visitor clinics, and it's just a matter of, there are lots of barriers apart from the service being there, and apart from knowing about it. So that we have to try and understand, and that's what this is about.
Sorry.
Third time lucky, try once more time. Oh dear. Right, you're still on mute now, Michael, if you want to come in with something. Hopefully it'll work this time.
Yeah, sorry. My camera's not working, so I've got a camera on one and what have you. Just on that latter point, I kind of just want to agree with what Heather was saying about there being lots of barriers, and certainly the consultations that we had with women about their experiences of maternity services. It wasn't necessarily a case of not understanding certain things. There are times that one of the big comments, or the big feedback was a lot of not feeling listened to. Yeah, so they didn't feel that they were being heard, and that their voices actually mattered. And I know that one of the topics that we've got coming up in a couple of weeks is at our event is actually looking at this, supporting women to navigate maternity services, because, as I say, it has proven to be a big issue, and I think it's one that all parties are keen to address.
Certainly, I just add in there, yeah, I agree with all that, Michael. Amy McLean from Flourish is running a series of listening projects for anybody who's given birth in the last 2 to 3 years in Birmingham. And if you got in touch with her, you can get people to go and attend those sessions. That would be one really good tool to use.
Right. Thank you very much, anyone. I think we're going to wrap up there as we're already 20 minutes over, but I've put our communities team email in the chat in case anyone wants to link out further with the speakers from today or wants any more information. I know, Michael, you said you want to share the resource around your upcoming event as well. We'll try and get that shared out to anyone through email as well. I just want to take some time to say thank you to everyone for coming today, and thank you to Nemo, Michael and Heather especially, all three of you, for presenting today. It's brilliant to hear about all the work that you've got going on. So thank you very much, everyone, and I hope you've enjoyed the webinar today.
Thanks.
Thank you very
Thank
much.
you.
I actually don't have access to the chat. Is it possible to get all the links via email?
Yeah, okay. If you can't access them, yeah, we'll try and send them out all at one. I'll contact the person
Lovely.
that's coordinated all these events.
Lovely. Thank you very much.
Thanks.
Thank
Bye.
you. Bye-bye.